Hello, everybody. So my talk will be about reverse shoulder arthroplasty. We all know that the current reverse shoulder arthroplasty that we are using right now was introduced and invented by a French surgeon called Paul Grammont. The first prototype was introduced in 1985, and it was formed of two-third sphere with a diameter of 42 millimeters. It was ceramic and cemented. In 1986, the second prototype, and it was two-third sphere with a 36 millimeter diameter, and it was metallic and cemented. The definitive one was introduced in 1991. It was half sphere with two diameters, 36 and 42 millimeters. It was metallic and uncemented. Actually, Paul Grammont was not the first one to introduce the concept of reverse shoulder arthroplasty or to reverse the anatomy of the shoulder. Many designs have been introduced by many surgeons and many centers, but unfortunately, they all failed. This is because the center of rotation was still in its position lateral, and that produced lots of stresses that led to glenoid loosening. Also, the method of fixation was not that good, so either loosening of the component happened, dislocation, or even scapular fracture. Grammont noted that, and he just insisted to put the center of rotation more medial and more lateral to reduce the stresses between the glenoids, bone, and the implant. I'm going to talk about something very important, which is notching, and it can be defined as impingement of the polyethylene cup with the lateral pillar of the scapula. That results in bone loss, as you can see in the X-ray. It has been well described by a grading system where grade 0, there is no notching. Grade 1, notching occurs along the lateral pillar of the scapula. Grade 2, notching till the inferior screw. And this area, it's an area of controversy because it depends how you put your inferior screw. So if you angle your inferior screw inferiorly, you can reach grade 0 much faster than if you put it in a parallel position. Grade 3, notching goes beyond the inferior screw, and grade 4, it's just reaching the central post. So actually, what causes notching? Classically, it's just due to impingement of the polyethylene cup when we do adduction against the inferior part of the glenoid and the lateral pillar of the column. So when we do adduction, we have abutment of this part of the polyethylene cup with the lateral pillar of the scapula. But Lederman et al. In 2015, they published an interesting paper, and they showed that it's not just a matter of impingements, but also there is friction that happens during rotation, range of motion, external rotation, internal rotation, flexion, and extension, as you can see in this video. Well, notching is not always mechanical. As you can see in this X-ray, notching goes beyond the inferior screw. So if it is mechanical, it should stop at the level of the inferior screw and doesn't go just beyond the inferior screw. So it has a biological aspect. So if we take a sample of this tissue and we look under the scope, we can just see that what we call granulomatous tissue, and there are multinucleated giant cells, polyethylene fragments, macrophages, bone debris, and all that we call it osteolysis. So it's not only mechanical, but it has a biological aspect. Actually, they did a finite element analysis to study the contact between the polyethylene cup and the glenosphere, and they found that contact was higher in the inferior part of the polyethylene cup. So the blue represent the polyethylene cup, and the green area represent the contact between the polyethylene and the glenosphere, and the red area represent the higher stress concentration during range of motion of the reverse shoulder arthroplasty. What about the wear, reverse shoulder wear? We put the reverse shoulder in a wear simulator, and we cycle it in a normal physiologic range of motion. And in this study, they found that the wear was mostly inferiorly. So the inferior part had the most wear. And as regard to retrievals from failed reverse shoulder arthroplasty, Nam et al. Noticed that the notching or the wear occurs mostly in the inferior part of the polyethylene cup. So from all the above, we can say that the contact patch was along the inferior aspect of polyethylene. The maximum stress was also along the inferior aspect of the polyethylene. The maximum wear was also along the inferior aspect of the polyethylene, and notching damage happened there. So this is the part which is very important, the inferior part of the polyethylene. What about the clinical evidence? Actually, there are numerous studies, and numerous studies have shown that there is no difference as regard the constant score in presence of notching. While there are only 2 studies, they have showed that in the presence of notching, the constant score decreased significantly. In another interesting multicenter study that was done in France in many centers, they just studied reverse shoulder arthroplasty done for any etiology between 1993 till 2010, and the follow-up ranged between 5 and 20 years. And they study about 1,035 cases with 5-year follow-up, as you can see. So they found that in less than 10-year follow-up, 16% of the cases had grade 3 or 4 notching. But when the follow-up was over 10 years, the notching was about 29%. So it jumped from 16% to 99%. So it's clearly obvious that scapular notching is progressing. It's not stationary. So from all the above, evolution of the Grammont concept has changed and was a must. So the normal 155 neck shaft angle prosthesis usually had problem of notching, as you can see, and to overcome this, so surgeons just advise we can overcome notching by either doing inferiorization, that means we place the glenosphere more inferior to clear this area of the lateral pillar. Either we put it more inferior or we just use eccentric glenosphere to have a 4 millimeter clearance, as you can see. Another way to overcome that by using a large glenosphere. So usually I put in my cases 42 or 40 size of the glenosphere just to clear this area and to avoid notching. Also lateralization, either you do it like Boileau bio-reverse shoulder arthroplasty, so by lateralizing the glenosphere, you also clear this area, or you can use a metallic lateralized glenosphere. Lastly, the standard is 155 neck shaft angle, but when we are using a 145 degrees or 135 degrees angle, you can clear up this area and prevent abutment of the inferior part of polyethylene cup against the lateral pillar of the scapula. So, to sum up, notching is not just mechanical, but it has biological and biomechanical aspects. We can prevent it by using what we just described. And I think it's better to avoid it because with notching, we just can endanger the glenoid, which is a very important element in reverse shoulder arthroplasty. As you can see, there are numerous designs as we described, but still further designs are evolving and they are present in the market as stemless or short stem reverse arthroplasty. So actually, till now, reverse shoulder arthroplasty is evolving and still evolving till we reach the best arthroplasty to have a better and reasonable outcome for the patient. Thank you for your attention.